Welcome everybody to this week's Power Hour. We apologize for the delay. As maybe many of you are aware, we have some technical issues. So thank you for your patience and for staying with us. We've had a little break for a few weeks. It's nice to be back. And today we're going to talk about unhealthy alcohol use. And our guests today are Dr. Dan Jonas and Dr. Joe Jordan. And as always, our moderator is Franklin Walker. My name is Christina Nattagdag. I have with me also my colleague Aubrey Cuthbertson. Power Hour comes to you from the KIPL Institute for Physician Leadership that sits with the North Carolina Medical Society Foundation. That's a mouthful. A few rules before we go on. We would love for you to engage with our guests today, but we do ask you to be on mute and unmute yourselves when you speak and ask a question. You're welcome to use the chat box as well. If there is a question we don't get to by any chance, we will make sure to follow up with you afterwards. And this recording will be available on the KIPL Institute for Physician Leadership webpage around Wednesday of next week. But without any further ado, I would like to hand it over to Franklin. Franklin?
Thanks, Tina. Welcome, everybody. It's good to be back after a little break and Labor Day. So we got a late start, so we're going to get right to it today. Want to welcome our guests again, Dr. Jonas and Dr. Jordan. Dr. Jonas, I'd like to start with you. Could you tell us a little bit about your practice at UNC and some of your research, please, sir?
Yes, and first, thanks for having me, Franklin. It's great to be here. I'm a primary care physician at UNC Chapel Hill in internal medicine. So I see adults in my clinical practice. I also take referrals for people with alcohol use disorder as I prescribe medications for alcohol use disorder. And so that's a portion of my practice as well. A lot of my research at UNC is focused on unhealthy alcohol use, and in particular, implementing screening programs and implementing programs to provide appropriate counseling for people with unhealthy alcohol use.
Super, thank you. Dr. Joe Jordan, can you tell us a little bit about NCPHP and what you guys do there?
Sure. First, let me thank y'all for having me on today. I appreciate this opportunity to speak with the medical workforce in North Carolina. And also, I want to say thank you to Dr. Jonas for his work in the field of alcohol use disorders, treatment, and counseling. The North Carolina Professionals Health Program was a joint effort of the North Carolina Medical Society and the North Carolina Medical Board to create a safe haven program where physicians and PAs eventually, and now all licensees of the medical board, could get the help that they need, Franklin, when they are experiencing a substance use problem, a mental health issue, and now increasingly burnout, which, as you know, is at epidemic proportions in the medical workforce. We are a free service. Anyone can call and they can remain anonymous to the licensing board, to the hospital, and they can get help. We have trained psychologists and medical doctors and counselors on our staff, and our sole purpose is to help physicians and PAs and other licensees, members of the medical society, find the help they need, get back to treating patients.
Super, thank you. As a follow-up to both of you, and so Dr. Jordan, since you're on right now, I want to ask you both about the effects of COVID or anything you've noted in your professions since COVID became a big deal in the United States and more specifically in North Carolina. We've talked a lot about COVID over the course of the Power Hour, how it's affected medical practices, people's mental health, et cetera. So I'm wondering if you guys have noted anything specifically related to COVID that's been notable. Joe?
Well, Franklin, do I have, say, a couple of hours?
Yeah, sure. Yeah.
I'll try to keep this as brief as possible. I don't think that I can really overstate the effect that COVID-19 has had on certainly on the field of medicine as a whole, but for the persons who are experiencing substance use disorders, I think it's been particularly difficult. I think it's contributed to burnout. The people that come in to meet with me almost universally talk about a sense of isolation and a sense of desperation on occasion when they feel that everything is so rapidly changing in the COVID-19 landscape. I would say that the overarching emotion that I hear people talk about is just frustration because of a lack of cohesive national policy around this, and also just feeling, this may sound a little, almost powerless to know what to do next. At the same time, I'm a little concerned about what the after effects are going to be when COVID-19 when a vaccine is developed, because my experience of working with medical professionals over the last 13 years, 14 years is that they're extraordinarily dedicated, and they will put themselves second or third or fourth, take care of patients, do everything they possibly can, and then once the crisis is over is when this is really going to land. And that's what I'm concerned about.
Yeah. I hate to come back to you once again, but I'm going to do it. In terms of what you guys have had to put in place at NCPHP because of COVID, can you talk a little bit about what you've done in your business model to change because of COVID?
Sure. Well, the first thing that we did is we had to put in protocols for the safety of the staff as everyone else. But I think what you're asking about is meeting with physicians and PAs. So we started working in doing remote interviews of persons referred to us. Our field personnel that go out and visit and provide supportive visits to the participants in our program began utilizing Zoom conferencing and FaceTime and other things like that to still make contact with participants. And of course, when people come into the office, we will follow the CDC protocols for safe distancing and mask wearing. What we have found is the ripple effects have been particularly difficult for persons who would like to be able to go to group therapy, would like to be able to go to support groups, would like to be able to go to treatment, but are unable to do that because there aren't the in-person element. So everything has moved to an electronic format, which I'm grateful for because it's still there. And I'm sure probably Dr. Jonas can talk about this from a counseling referral perspective is the positive, you can get people into a group. The negative is it's not a group by the traditional means.
Right. Thank you. And so I do want to loop back now to Dr. Jonas. Same set of questions to you, and I'll repeat those if you need me to. So please, sir.
Yeah, I think great points, Joe, and really important question about how COVID has affected everything. I think it seems there's a new headline every day related to either depression or stress or isolation or alcohol use or drug use being increased with the pandemic, and it's pretty clear that all those things are going up, and with stress and unemployment going up, violence has also been going up. So there are a lot of issues here that are somewhat intertwined. Whenever we're talking to practices across the state now, as we're trying to help them build programs to screen for unhealthy alcohol use, one of the things that comes up is, we're overwhelmed right now. There's so much that we're trying to do. It's hard to do another thing beyond what we're already doing. And one of the things that we emphasize with alcohol and with drugs is that, program to identify these things and help people is needed more now than ever, because these problems are really increasing, and they've already been big problems for quite a long time. Even before the pandemic started, unhealthy alcohol use was number 3 on the list of preventable causes of death. And so it's really important to identify it and address it.
Yeah. Dr. Jones, what are the latest guidelines from CDC on level of alcohol consumption as it relates to unhealthy alcohol use? As in, if I'm having 1 glass of wine a day, that may be okay. If I'm up to 2 or 3, I know that changes over time. Can you?
Yes, yes. So absolutely. So the CDC and the NIH and a number of other groups have recommended limits that they've had in place for a while now, and they differ by age and sex. So for men under 65, it's 4 or fewer drinks per day and 14 or fewer drinks per week. For all women and men 65 and older, it's 3 or fewer drinks per day and 7 or fewer drinks per week. So those are the recommended limits that many groups have put forward for a while now. If you follow recent press, there are some things that are getting headlines now from groups coming out that are basically dietary guidelines groups, not the CDC, not the NIH, that are saying that the lower limits should be for everybody. And it should be 3 or fewer drinks per day or 7 or fewer drinks per week for everybody. So there's some ongoing debate there for where to draw the line. And that's actually, even though it's getting a lot of press again now, it's not a new debate. That is a decades old debate because it's one of these risk factors when you look at the curve for the association between alcohol use and mortality or any other outcome. There's a line that's going up, 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 up. It's not that there's a clear point where we can say, oh, it just went up between 3 and 4 drinks. We're looking at a line and we're saying, using judgment and applying our values and how high is the risk and trying to decide where it makes the most sense to set those recommended limits.
And as a follow-up to that, those guidelines by those various and sundry groups, you've got, beer and wine in one category, and of course you got liquor in the other category. When you say 3 drinks or less, are you putting those in the same category, or does it break down different if you're drinking liquor versus beer and wine?
It does not break down differently. It's the same breakdown. I think, to me, I'll take that question to bring up the idea of what counts as 1 drink. And so there is, there are a number of graphics out there that demonstrate or that illustrate what counts as a standard drink. And so for beer, it's 12 ounces of a 5% alcohol by volume can of beer. With microbrews proliferating, there's all these different percent alcohol by volumes that you can get. So sometimes one beer, if you ordered 1 beer at a bar, might actually be 2 standard drinks if you've got a stout that's got 10% alcohol by volume or something like that. So it's kind of fun and interesting to me anyway to look at local microbrews and sort of see what their range of percent alcohol by volume is. And whenever I go talk somewhere, I find the most popular microbrew and I try to put one of theirs up on the screen and show how many drinks that it might be. For liquor, it's 1.5 ounces of 40% alcohol by volume. So 1.5 ounces counts as 1 standard drink. And when I talk to the medical students at UNC, I always like to put up a picture of a Long Island iced tea. And I ask if anybody knows the recipe for it and how to mix it. And there's always 1 or 2 that used to be bartenders at some point or still bartending, and they know the recipe, and have them figure out how many standard drinks that turns out to be. And it's 2.5 to 3.5 standard drinks in a single Long Island iced tea, varying depending on how it's mixed. So there's some fun behind that question of how to think about beer and liquor.
And a quick follow-up, are there any benefits to consuming a glass like red wine, 1 per evening or something like that?
So the current thinking is no. There's been debate about this for a long time, because when you look at these curves that associate alcohol intake and all-cause mortality, or alcohol intake and cardiovascular mortality, we get what we call a J-shaped curve or a U-shaped curve, where the beginning of the curve goes down, below the x-axis, indicating that there may be some benefit, and then it comes back up and it starts to increase at some point. And so historically, people looked at that and they said, there may be some benefit of really low amounts of alcohol intake. Now more and more, there's becoming more agreement in looking at those studies that the ones that show the curve dipping have some significant risk of bias in them, and that the studies that have been done the best don't show any benefit of low levels of alcohol intake. And so the current thinking is no, that there's not a benefit. And if you ask most alcohol experts, if someone's a non-drinker, like if they're abstinent and they've never been a drinker and they've never had an alcohol use disorder, they might say, should I start drinking a little bit for my heart health? And most experts agree that the answer to that question is no, you shouldn't start drinking for your heart health. It's probably actually going to increase your risk of health problems.
Interesting.
Franklin, if I could jump in on that, there was a 2018 article in The Lancet that looked at 195 countries, 694 sources of data, and 592 studies. And for the research geeks like myself out there, Dr. Jonas is exactly right. They found a zero health benefit for drinking, and in fact, it contributes to a number of cancers.
Interesting. Yeah. Well, I thought it was interesting when we went into the shutdown for the state and they classified essential and non-essential businesses, of course, and you know where I'm going, that the ABC stores were classified as essential businesses. So as you've got your hand over your mouth, I want you to react to that statement and tell me what your thoughts are on that.
You really want me to?
Yeah, I do.
Franklin, I'm not sure how and what the reasoning was behind classifying an ABC store as an essential business.
Right.
I'm not sure that I can speak cogently to that. I'll leave it at that. Okay.
No, I just thought it was an interesting, as Dr. Jonas said, there's some fun facts behind some of this stuff that I think it's interesting to explore. I do want to get into talking about the short and the long-term effects of unhealthy alcohol use. And we've touched on some of it a little bit about heart health or lack thereof, but certainly there's a plethora of other issues, health issues, that manifest themselves over a lifetime of folks that are using alcohol in excess. So, Joe, do you want to start out on that, and then we'll loop back to Dr. Jonas?
Sure, although I will defer to my medically trained colleague in this matter if he wanted to jump in at any point and verify any of my statements. I think the short-term effects are the kind of classic ones that you will see from alcohol is, and what I tell people when they come into my office on a referral because of a DWI is that the first effect of alcohol is disinhibition. And then the second short-term effect is impaired judgment. And those two can combine for very poor decision-making, especially when alcohol is consumed in excess. And then, of course, there's also the deleterious short-term effects of alcohol use, which are dehydration and headache and things like that people talk about as commonly referred to as a hangover. Dr. Jonas, anything you want to throw in on there for the short-term effects?
I think that is really well put, Joe. I think I guess the thing I would add on the short-term effects, and in my mind, I was starting to think about the health outcomes or the adverse health events that could happen really soon or in the long term. And so I guess what I would add is motor vehicle crashes as being one of those, short-term bad outcomes of unhealthy alcohol use, obviously associated with binge drinking. In North Carolina, there's about 4,000 deaths per year that are attributed to alcohol, and most of those are from motor vehicle crashes. And so that is certainly one of the worst short-term effects.
Yeah, I remember when I learned that there's like 261 deaths a day attributed to alcohol use, and that most people think long-term effects of alcohol use are going to be cirrhosis of the liver and things like that. We did alcoholic hepatitis and heart disease and elevated cholesterol and all of those things. But In fact, when you look at the 95,000 deaths per year from alcohol use disorder, or from alcohol use, or attributable to alcohol use rather, it's one of the lead, and I heard you say this earlier, it's one of the leading causes of preventable causes of death in the world. And when you mentioned binge drinking, I think our listeners would be surprised to learn that binge drinking is 5 or more drinks in a 2-hour period, or that's the definition that I've heard. 4 drinks for a woman, which is another one of the gender differences that you had mentioned earlier. What do you think?
Yeah, I think that's right on. And I think whenever looking at the data and talking to people about alcohol, it's really interesting to see what the preconceived ideas are about what adverse health effects that it causes. And often people know about the liver effects, and they know about the short-term, disinhibition, and they know about some of the things with motor vehicle crashes. But I think the other one that I often highlight when I'm talking to patients who are drinking above the recommended limits, and I want to explain the health risks of doing so. The other one that I often highlight is cancers. And I think it's surprising when you look at the data on how much the risk of various cancers goes up at relatively low levels of regular alcohol intake, even at levels within the recommended limits. Like even if you're drinking within the recommended amount, the risk of a number of cancers goes up. And in particular, it makes sense. It's the things that alcohol is touching. So, the mouth, esophagus, throat, stomach, and the GI tract. So alcohol, in lab studies has been shown to be a direct toxin, and that's, there's a good explanation for why it causes all these cancers. There's also been a lot of literature about increased risk of breast cancer over the past 5 or 10 years. And so I think that's an important long-term effect to talk with patients about.
Yeah, I read something recently where just 1 drink a day by a woman increases her chances of developing breast cancer. And I don't remember exactly what the percentage was, but I was just amazed that in one website or source of information will be told 1 drink a day is healthy for you. And in fact, it actually increases the chance of 7 types of cancer, one of which, of course, is breast cancer.
Interesting.
Yeah.
Dr. Jonas, I want to talk a little bit about medical students and residents and what you may have noticed, not just in your research, but as your own journey as a physician through medical school and residency. As the spouse of a physician, I remember vividly my wife going through a very stressful time of med school and residency. And I'm wondering what your research and what your observations are in present day medical education and how that relates to our topic today.
Yeah, I think, and so I'll talk more from my clinical experience and personal experience rather than from a research perspective on this question, because this specific topic isn't something I've done research on myself, but certainly when I talk about alcohol, a lot of the audiences I'm talking to are medical students or residents. And so I have a couple slides that I always put in there that show data from questionnaires sent out through the AMA master file that ask physicians about their alcohol use. And those results of those questionnaires show that physicians have a rate of unhealthy alcohol use that's a little above the general population. And they have breakdown by specialty as well, which I find fascinating. So your wife's a pediatrician, so she's in one of the groups that's in the much lower levels there when you look at how they break down. And some of them, are much higher than that average, than that population average, and some are much lower. So it's interesting to see that there is this variation by specialty. And so somehow, whether that's people select a certain specialty because there are other people behaving like them already in that specialty, or whether there's something about the specialty itself that leads to that behavior, I don't know. But with primary care in particular, being in a primary care setting, There's a lot of burnout that maybe relates to loss of control and flexibility in certain jobs, and that has increased unhealthy alcohol use. So I think, we've seen some increase there and some concerning trends.
Right. So Joe Jordan, I want to come back to you. And I noted in doing a little research for today's topic, I went to your website and there's a really neat new video that you're talking for several minutes. And you say, since the inception of NCPHP, you guys have helped about 4,000 physicians. So that's about an average of 191 per year, which is actually interesting. We just talked about medical school. That's about the average size of UNC's, one class. Not to take a dig at my former place of employ, but anyway, if you can talk a little bit about what you've seen in your term there at NCPHP in terms of the trend lines. I just mentioned an average, which was over the life of the program. Talk about trend lines. What's the average timeline for someone that comes into your program? And I'm sure it varies, but I'm sure there's an average. And how do you define success at the end of trying to help somebody?
All great questions, Franklin, and appreciate you asking about that and bringing up our website where we like people to visit us and hear about what it is that we do. So when you talk about an average of 191 a year, we're probably seeing probably about 220 physicians walk through the door at NCPHP this year to ask for help in regards to a substance use, mental health, or other issue. And that has been steadily going up since I came there 13 years ago, and certainly is more than when the program first started. So that average is, and it's been over 200 now for a good bit of time. The trend lines that I'm seeing is we're seeing more female physicians come through, which I think accurately reflects the workforce as a whole. We are also, and I was really glad to hear Dr. Jonas talk about the burnout, is we are seeing increased incidence of people that when they are referred for one reason, and that might be a driving while impaired conviction, a incident at work, a behavioral outburst or something along those lines, even depression or anxiety, that one of the contributing factors to that is a feeling of powerlessness, a feeling of lack of control, a feeling of insufficient reward at their job. Now, and I'm not talking about money. That can be emotional reward or psychological reward. So all of those things contribute to a feeling of being burned out. And so we're definitely seeing increases in that. You had mentioned residents, and there's a trend that I would like to address and because I have this opportunity, and that is a unfortunate trend in residents to see that cannabis and marijuana is somewhat innocuous, and that can partake of that substance when they are in areas that it's legal, and then return to North Carolina and expect that if they have a positive drug screen, everything's going to be okay. That's not the case. So when I speak with med students or residents, I talk with them about understanding that they're licensed to practice medicine in North Carolina, and they need to be cognizant of that fact. The other thing that I've seen as a trend is much more binge drinking and acceptance of drinking as a whole. We have a large brewery culture in America. In fact, Asheville is one of the largest microbrewery areas around, and people do not understand that the microbrews are quite frequently more stronger than a average beer. And I've had a number of situations where people have been involved in driving while impaired charges or wrecks where they did not realize that what they were drinking did not equate to a regular 5% alcohol beer. And so, again, I was glad to hear Dr. Jonas mention that as well. You asked finally, how do we define success? And Franklin, that's defined differently according to the situation. We try to individualize as much as possible each case, but in a general term, if that person is working in their chosen field of practice at the close of their interaction with us, we consider that to be a success. And we try really hard to help them first take care of themselves so that they can then take care of patients. And making that shift in the thinking of a person that is so used to devoting their waking moments to the care and healing of other persons to allow themselves to be taken care of and to seek healing. If we're able to do that, then we find that people do pretty well at getting the help they need and then eventually getting back to doing what they love best, or even doing that while they're healing. So they may be with us for a couple of months. They may be with us for 6 months. They may be with us for as long as 5 years. The national standard for someone that has a severe alcohol use disorder or moderate alcohol use disorder, which used to be called alcohol dependence, is that they be monitored for 5 years. And with that, yeah, and there's some studies out there that people can access, or I can get to them, and that results in a success rate, which is defined as working in their chosen field of practice and licensed, of around 80%. So that I'll take those numbers any day.
Yeah. I do have one follow-up question, and you talked a little bit about 220 people, I think, this year have come through, or maybe, or they're projected to.
Roughly 220, 225, 215, somewhere around there.
More females in an increasing trend. Now, I know that the Medical Society, Medical Society Foundation, we talk about this program at the office, and I think having worked with you on several committees and some other things, you're really out there publicizing that this program exists, which is a great thing. So I'm wondering if part of what's happened, as well as the maybe underlying increase in unhealthy alcohol use, has helped increase your business, if you want to term it business or treatment, but also the fact of the awareness of NCPHP as a place that folks that need help can go, that maybe years ago it was kind of under the radar. Do you have any of that sense that there's more awareness?
Franklin, I would love it if that were the case, because I've, for a while there, I was trying to get out and really, share our story with as many people as possible. Unfortunately, COVID-19 greatly decreased the opportunity for me to get out and speak at, universities and at medical society events. So we've had to go a little different. We talked to the medical staff services, and we're sending a letter out with, in fact, that's coming out this month. We're sending a letter and a jump drive with some information about our program so that people can know a little bit more about it. We've been mentioned in a medical board issue. I do want to put a plug in that the medical board is taking up the tragedy of physician suicide as something that they want to address. And I do have to mention, of course, Bob Seligson, just always effort to address that tragedy of physician suicide, which I personally believe is the last and tragic end of someone dealing with a substance use, mental health, or burnout. And at least my hope is that we can keep that from happening, because it's any suicide is a tragedy.
Yes, sir. Well, thank you. Dr. Jonas, I want to come back to you, and I know that you're involved with AHEC's STUN project. And so could you tell us about the project, what it does, and give us some details on that, please, sir?
Yes, thank you, Franklin. Yeah, we're really excited about this project. STUN, so it stands for Stop Unhealthy Alcohol Use Now. It's a program that we're starting to work with practices across the state to help them implement a system to identify unhealthy alcohol use by screening for it in their patients, and then to also provide the appropriate counseling or referrals for those who have identified either risky drinking behavior or an alcohol use disorder. There's a big team of folks working with us on this from NCPHP and from UNC Chapel Hill. And we're off to a really good start. We're not quite 1 year into the project, so it's relatively new, and we've picked up a lot of momentum over the last few months after pausing for a while. Once the pandemic started in March and April, everything was put on hold for a little bit, and then we realized we really needed to get back up and running because unhealthy alcohol use was increasing, and this was needed now more than ever. The practices that we're going to work with, we're still recruiting and identifying practices, so if there are practices out there that want to be involved, we'd love to work with you. They do have to be small to medium-sized practices, so we want practices that are 10 or fewer providers within that practice. So like my large practice at UNC Chapel Hill Internal Medicine, where we've got kind of the big academic practice and all the residents, is not eligible because we've got too many people. We really want to work with the smaller practices. A key piece of this is a quality improvement mindset, and we want to meet practices wherever they are currently with whatever system they have, or even if they have no system at all, and we want to help work with them to build their system or to improve their system. We've also got a lot of materials that we've developed to do trainings for how to do brief counseling in primary care, how to do motivational interviewing in primary care, which to me is one of the best parts of this whole thing. Once I learned it and went through it, learning motivational interviewing for unhealthy alcohol use has so many other applications. Now I use it for any behavior change. Behavior change is hard, but having this basic skill set of motivational interviewing is really applicable to weight loss behavior change. It's really applicable to smoking cessation. It's applicable to a number of other things. So it has benefits that go well beyond the program.
Super. How long is that going to continue, Dan?
At least 2 more years.
Okay.
I probably should say at least 3 more years with what we're looking at right now after the pause. And then depending on how much uptake there is and how much demand there is and whether it's still needed or if practices are ready and set on their own, then there'd be some reassessment toward that latter part of the program.
Super. Thank you. I want to turn to Tina now. I think she has another question for the guest. Tina?
Yes. I have a comment as well. As I was listening to you talking about the alcohol use in terms of driving as motor vehicle accidents as a consequence, right? I don't know if you ever thought about the limit for alcohol in North Carolina. It's very high. 0.08 is you can drink fairly a few drinks, so there might be a policy issue there that, we could visit. But I wanted to talk to you about something else or ask you about something else. And I just stumbled upon a article in JAMA from last year, and the title is intriguing. And it says, Unhealthy Alcohol Use in Primary Care, the Elephant in the Examination Room. So I would love to hear your thoughts around, there are great projects, programs and tools and help in order to start screening for these things. But we have to talk about the fact that it is a lot of shame connected to having an alcohol use disorder or, using that. So I want to hear your thoughts around that. What are your thoughts around addressing that? And we can refer to it as the elephant in the examination room. And in particular, if there is someone who, as a physician or clinician, him or herself has an issue, right? So would love to hear your thoughts around that.
Yeah, a great question and a challenging issue for sure. There's a long history of stigma and shame around alcohol and drugs. And I think there are a lot of things that have maybe try to improve that in how we use terminology and what words we choose when we ask questions. And I think that's an important piece of this is how we talk about it. I certainly think that there's been good momentum towards less stigma for alcohol and drug problems, and having more of an approach of realizing here's somebody who we need to help, and we want them to, optimize their long-term health and their function, and less labeling and less stigma. But so I'll give some examples. So for example, historically, the terminology alcohol abuse is a stigmatizing term, many people feel, and it sort of blames the individual. And DSM-5 removed that term, and it removed alcohol dependence. And now the preferred terminology is unhealthy alcohol use, if we're going to talk about the umbrella of everything in this space. And then alcohol use disorder is same thing for substances. Now the DSM-5 has removed substance abuse and substance dependence, and we talk about substance use disorder. I think that those are important changes that help us to view what this is somewhat differently. But even when we ask the screening questions, I guess that's the other example that I'll use. I think some of the older screening questionnaires that were being used had the blame built right into the questionnaires, actually. And so getting more toward the ones where we start by saying, do you sometimes drink beer, wine, or other alcoholic beverages? And then if it's a yes, a very factual follow-up, how often in the last year have you had 4 or more or 5 or more, depending on their age and sex, drinks on one occasion? And so we're asking the questions in a different way that's more factual. Also asking the questions along with other health questions. So it's in a questionnaire with questions about smoking, I think has helped it so that people expect their doctor to ask them about these things when they see their doctor, and they understand that these are questions that we're asking because we want to optimize their health. I think those are some things that we can do to help out with the stigma. I think Joe probably has a lot more expertise actually in this space than I do. So I'd love to hear his thoughts on this as well.
Thank you, Dr. Jonas. I appreciate it. I do have some thoughts around this, and I think that some of what we're doing right now is letting people know that 10 to 12% of the population at some point in their lives is going to deal with a substance use issue, an alcohol use issue. Unhealthy alcohol use perhaps affects far more, but just 10 to 12%, that's 1 in 10 people. And so it could be me, it could be you, it could be anyone. And what we know from the studies of genetics is that it's very similar to other genetically determined illnesses, that it is a disease. And going back to something we were talking about earlier, the Physicians Health Program was originally started to combat the shame and stigma that people experience as a result of having an illness, and helping people to understand that this happens to people sometimes, just like the shame and stigma that's associated with mental illness, another thing that we're trying to combat in our culture. And I agree, there's been some good momentum in people learning about the fact that it's an illness that affects people all around them. It could be someone in your family. And I'm glad that we have people like Dr. Jonas and like y'all that are willing to talk openly about this. We actually are creating some videos of past participants that we'll be posting who are now successfully employed as physicians and living full and rich and rewarding lives to destigmatize this illness that people suffer from.
Super. Tina, did you want to follow up, or do you want me to take back over?
No, I just want to say, yes, please, Franklin, back to you. Thank you so much. I appreciate your answers. I think that's such an important part of this, because I do think that it's so easy for patients to kind of and so hard for a clinician to actually understand, if a patient can say, no, I don't drink, I don't, or, heavily say, I'll take 1 glass of wine a day, whatever the level that is okay, right? So I think, talking about it and sharing stories and destigmatizing is extremely important. And I think we're just starting that, right? So thank you so much for sharing that. Sorry, Franklin.
I do want to say that Dr. Jonas's comment about motivational interviewing, which is a very non-judgmental approach to addressing the issues of substance use and has become the evidence-based practice that is utilized within the field with regularity to help people not feel judged and not feel frowned upon, but actually welcomed to address their own ambivalence and their own lack of knowledge or lack of understanding of what's going on with them without putting upon them any judgment around that. So I think that is critical, and it's something that I'm a big proponent of.
Yeah, I agree with you. I think that's a great way to also get to the hidden assumptions, right? That is kind of like impeding this. Franklin?
Thanks, Tina. We're getting close to the end of our hour, so I've got one more question that I want to pose to both of you. What strategies will you recommend to avoid unhealthy alcohol use? And Dr. Jonas, I'll go to you first.
I think making sure that there's awareness of the potential adverse health outcomes of unhealthy alcohol use is really important. I think trying to identify unhealthy alcohol use early in people's lives is important because there is sometimes a trajectory from risky drinking behavior without an alcohol use disorder to then increase in risky drinking behavior more and more over time and eventually leading to an alcohol use disorder. So I think early identification is one of the important things, as well as awareness for sure.
Dr. Jordan.
Sure. So one of the things that I talk with residents and medical students about when I'm talking is doing a cost-benefit analysis of what are you getting from your use of alcohol versus what is your use of alcohol doing to you, and asking them to be cognizant of the potential ramifications of that extra drink. I'm not so naive as to think that we're going to eliminate the use of beverage alcohol in our culture. So I ask people to just take a moment and think before they start their use of alcohol, because once you start, the disinhibition and the lack of judgment kicks in, and what used to be probably not a good idea all of a sudden seems to have some appeal. So I really ask people to think and plan before they consider whether or not it's the right time or the right amount of alcohol to use.
Right. Okay. Well, we're just about out of time, and I want to thank both of our guests today. This has been a really, really interesting discussion. I think very pertinent, particularly with COVID overlaying our society today and causing a lot of stress up and down the line. So, Tina, I'm going to hand this back to you.
Perfect. Thank you, Franklin. And I also want to thank you so much to our guests today. It's been a very great conversation, and I thank you so much for taking time to be here today. I also want to let our audience know that we do have a webinar coming up on September 30, where we'll continue to talk about this topic, but we will go in depth on that tool that Dr. Jonas is talking about in the STUN project. So please join us for that. You can find all the information around that on the KIPL Institute for Physician Leadership webpage, and there will also be some information sent out around that closer to the date in the morning rounds. So be on the lookout for that. Thank you so much. Thank you for your patience in the beginning as we and had some technical issues. It was great to be back with Power Hour, and this wraps up to this week's Power Hour. As just as a reminder, the aim for Power Hour is to have exactly these kinds of conversations around important topics and to build collaboration and to build community. So thank you for being a part of that, and we hope to see you back in 2 weeks for another topic, which is going to be around racism again, and you can find the information for that on the KIPL Institute for Physician Leadership webpage as well. Thank you so much. Have a nice weekend when you get to that point. And again, thank you so much to our guests for today.